Good evening, everybody. I am Dr. Parag. I am pediatric cardiologist working in Mumbai. I am presenting this series of fetal echo assessment out of my interest and just to propagate the understanding of the subject. I am being in this field for last 15 years or so. So let's start. What is the objective of this lecture series? I will be not going into general aspect like indications and other things. I will be more focusing on technical aspects of fetal echo, which are like image acquisition, image optimization, analysis and interpretation of images, understanding segmental anatomy of heart and its relevance to fetal cardiac defect, understanding normal anatomy, common defects as well as its rare presentations, understanding spectrum of common defects, uncommon defects, some rare or difficult to diagnose defects. We will try to cover most of the congenital heart defects. I would request you to observe this presentation in low light because all these images I have taken in echo room in a dark room. So you will appreciate their anatomy better if you see them in dark room. So let's begin. Now coming to image optimization, there are ISU-OG guidelines will more or less follow them. We have to choose transducer. I generally prefer C5 or S5 on my Philips machine. Narrow the image sector, reduce the image depth. Focal zone of the image should be at the level of the heart. Harmonic, compound imaging, speckle reduction, zoom images, but avoid too much magnification, high contrast, select high frame rate. Most important thing that I would like to mention is that a caudocranial sweep. This is a very important thing. Take a loop, play it again and again, again and again. That will help you to understand the image better. Most important thing I follow in a fetal echo is do a checklist. So I try to do all fetal echo in a peculiar way so that I try to avoid missing things. So the things I follow is determining left and right side of the body and determining situs, situs solutus, inversus, isomerism, deciding the cardiac delay. Then segmental cardiac apex, deciding the segmental arrangement of heart, whether it's at the most important, there are three segments: atria, ventricle, and gate arteries. And there are two connections: atrioventricular connection and ventricle to gate arteries connection. So we can get all possible permutation and combination in this setting. So all things put together makes the final diagnosis. So coming to the first thing of deciding left side and right side, I generally follow is keep the baby's head on the right side of the image and turn the transducer in 90-degree. So we come to know about four possible arrangements. So in the way it's a clock and we have to understand which is the left side and right side. It's helpful that we keep these images printed or posted somewhere in our echo room. So whenever in doubt, we can refer it to. Other is rule of thumb. If the fingers of right hand are in the position of head and the thumb points towards the left side of the body. So it can be four possibilities in bridge presentation or in cephalic presentation or even in a transfer live. We can definitely decide which is the left side of the body. Then coming to deciding situs. After deciding left and right, we have to decide what is the situs. Situs is basically three parts of situs: abdominal, thoracic, and cardiac. Abdominal situs is about arrangement of liver and inferior vena cava and stomach and spleen. Thoracic is about bronchial situs and lung. Bronchial is hypoarterial bronchus, right and left side, trilobed and bilobed. Trilobed is right lung. Cardiac situs is atrial arrangement. Atrial arrangement we cannot see on echo, but we generally follow them it on cardiac pathology specimen. Right atrial appendage is larger, triangular, pectinate line up to crux, and left is smaller, like little finger, not up to crux, no pectinate line. The most consistent thing is that generally the thoracic situs goes hand in hand with cardiac situs. And one more important thing we have to remember, IVC always runs into morphological RA. There are no exceptions to it till date. In case of situs ambiguous, we have to generally do a syndromic diagnosis, which is right isomerism or left isomerism. So deciding situs on mainly three things: thoracic, abdominal, and cardiac situs. Now, atrial situs is of following possibilities. Right atrium is on right side, it is situs solutus. The right atrium is on left side, and left atrium is on right side, it is situs inversus. Both atrial appendages are of right morphology, that is right isomerism. Both atrial appendages are of left side, that is left isomerism. So this is all possibilities. After atrium, we have to know what is the ventricular morphology. Ventricular morphology, right and left ventricle. Right is apical trabeculation are there, while left has got a smooth apex. Moderator band is on the right side, left has no moderator band. Tricuspid wall is more apically attached, left mitral wall is more cranially pressed. Septophilic attachment of tricuspid wall, subwall, and mitral wall is not attached to the septum. There are few controversial points like septomitral or mitral and aortic continuity, aortomitral continuity, or aortopulmonic continuity in a TGA setting. But there are cases where infundibulum has been observed on LV. Also, infundibulum is independent of the ventricle. It can be seen on either side. So these points are not taken very hard and fast. Just a pictorial presentation to make things clear for you. This is the right ventricle with apical trabeculation and septal attachment of tricuspid wall. Apically placed tricuspid wall as against mitral wall, which is cranially placed with sup wall ventricle. This is can same be seen. These are the pectinate muscles on right atrial appendage. This is the appendage on this side. Last is gate arteries. Aorta is the vessel that supplies neck, that gives rise to neck vessels, and pulmonary trunk gives rise to or supplies lung. So it branches into right and left. So this is the definition of these great things. Now coming to caudal sweep, these are the 5-6 images that we will see. Generally, people take each image individually and then try to make a sense out of it. But we will see how to take a sweep. We'll first analyze individual image and then we'll try to analyze the sweep also. So this is how sweep is taken. Caudal cranial sweep. This is the transverse section at the abdomen, or you can say at stomach level, stomach bubble, aorta, inferior vena cava, liver, and left side. This is the understanding of cardiothoracic ratio, how it is calculated. Morphological presentation of major anatomical structure at the mid-thoracic level, that is apical fourth chamber. Cardiac axis is around 35 to 45. This is left ventricle, right ventricle, LA, RA, mitral wall, tricuspid wall, foramen oval, aorta. This is seen in either view. So this is the snare loop image of the abdominal. We can see pulsatile flow in aorta and pulse wave Doppler suggesting aorta is on left side of the spine. Now this is the four chamber view of the heart. The things that we have to understand while interpreting four chamber view is that see four chambers are there or any chamber is absent. So we have to see atrium here. This is the left atrium. This is left ventricle. This is right ventricle. This is mitral wall. This is tricuspid wall. This is bulging intrarectal septum foramen oval. So bulging represents the right to left flow across the oval foramen. Then there is a pulmonary veins and this is aorta. So I always try to look at the moving image, try to understand, try to appreciate the movement of valves. So again, same image. I have taken this image because in first image I could not show apical trabecular or moderator portion of the right ventricle. So this is the right ventricle. This is in some smaller fetus, 22 weeks. Now demonstration of pulmonary venous return, pulmonary veins. This is blue flow and red flow. They are turning into left atrium. We have to keep Nyquist limit low. We can put a pulse wave Doppler and demonstrate pulmonary venous flow. Now demonstration of left ventricular outflow tract. These all images I have taken as per standard guidelines. You can refer to them. Just this is a beginning. So while tilting the probe towards the right shoulder, we get an image which is more like a long axis view. We see the left ventricle, right ventricle, left ventricle outflow tract as shown with blue, and then aortic wall opening and proximal aorta. Okay, we can also see bifurcation of to LPA, but that's not important in this. Now coming to the right ventricular outflow tract, it is more like a modified short axis view. We can see bifurcation of MPA into left pulmonary artery, right pulmonary artery, and continuation as a duct. Arrangement of superior vena cava, aorta, and main pulmonary artery. This is three vessel view, three vessel trachea view. This is MPA, aorta, SVC with LPA coming out. Okay, both are diverging on the left side of the spine, showing left aortic arch. These things are important when we will talk about right aortic arch, right arch, left duct, vascular rings, other things. So always remember which side aorta is going, which side MPA is going. In another case, going to important thing we have to note is that there is no flow reversal. Both aorta and main pulmonary artery flow are in the same direction. There is no flow reversal in either of the vessels. Flow reversal is there. It's a sign of a critical stenosis of either of the semilunar valves. So important is to understand it. Now taking the sweep. Sweep is an important thing that first there is a stomach bubble, then comes four chamber view, then comes LVOT, RVOT, three chamber view. So we are seeing LALV aorta connection, RARV MPA connection. Stomach apex is on cardiac apex is same side on the stomach. Okay, so this will give us the segment anatomy. So this is the sweep and understanding which image is seen at what level. Sweep in a smaller baby, just try to understand stomach bubble, cardiac apex, and segment anatomy. Again, I'm running this 3-4 times so you understand how to analyze sweep. These images are not part of routine imaging. This is aortic arch seen from from LV origin is more posterior than the pulmonary artery. It is more U-turn than the PA. It is little difficult to obtain in when fetal position is not very great. Try to note the origin of one neck vessel that is seen here. This is a neck vessel that is RSA. You can see a trivial flows horizontally seen. Next is MPA, ductal arch going down. It is more anteriorly placed, arising just behind the sternum. Now, these are my recent participation of Mumbai Marathon. Now, coming to the individual cardiac defects. Now, we will start with ventricular septal defect. VSD are very common septal defect, and we will try to see how we can understand the VSD or get the diagnosis of VSD. VSD are basically classified into four main types: perimembranous or membranous, muscular, inlet and outlet, and we can have any combination of this. Premature baby have more frequently mid-muscular VSD, or term babies have more frequently perimembranous VSDs. We are discussing only isolated VSD in this section. VSDs with another abnormalities will be discussed in relevant section. So, understanding, these are the mid-muscular VSD, apical muscular, anterior trabecular, posterior muscular. This is perimembranous. The yellow part that you see is the inlet portion, is the tricuspid wall. Below this we get inlet VSD, and these are the outlet VSD just below pulmonary wall. Now, radiologically, the most important thing in a mid-muscular or perimembranous is to demonstration of TS sign or TR defect. Septum is hypoechoic than usual. Okay, so these are the, look at this hypoechoic portion. So this is a T sign, this is the interventricular septum, hypoechoic IVS. These are the two. Great. These are the flow through the VSD. This is the same VSD I have shown in different ways. So this is the color flow image Doppler with loop, and you can see the good ventricular contractility with VSD, both in inlet portion and apical septum also. There are multiple VSDs. Same VSD, the inlet VSD has got a extension to the A. We can, somebody can say that this is a AV VSD, but the tricuspid wall is little apically placed than the mitral wall, and there is no AV wall regurgitation. Primum septum is present, so this is classified to be a interventricular septal defect. Same VSD. Another patient. We will discuss this patient in detail. This is apical trabecular septum, and this is the apical VSD. There is a VSD, another in perimembranous septum. I'll show you in another image. So this is the perimembranous VSD seen here, and the VSD is apical. The cardiomegaly is also there. This baby had LV dysfunction along with the VSD. So this is a flow demonstrated across the VSD. Color compare. Another baby around 21 weeks. A mid-muscular VSD is multiple. All these images I have acquired over last few years. Okay, in apical VSD, mid-muscular VSD, these are two VSD that we can see. Generally, multiple VSD are easily seen. Perimembranous VSD is difficult to demonstrate because the septum is very thin and they are frequently missed. Coming to the next topic, coarctation of aorta. Now, coarctation is narrowing of aorta at the site less of isthmus. We can on fetal echo just suspect the diagnosis. There is no confirmatory test to diagnose coarctation unless the coarctation is very severe. We have to keep our threshold low. There are few telltale signs like RV dominance, main pulmonary artery is very dilated as compared to aorta and three vessel view. Normal the ratio is 1.2 as to 1, but in second trimester it is more than 2 as to 1, then suggestive of coarctation. Z score of aortic arch at isthmus. These are, if the Z score is less than 3, then we suspect the coarctation of aorta. Why it is important? I'll just tell you. Coarctation is associated with many anomalies like bicuspid aortic wall, aortic stenosis, VSD, hypoplastic left heart syndrome, Schoen complex. Schoen complex is obstruction at multiple levels like mitral wall, subaortic area, aortic wall, toxic being anomaly, tricuspid atresia with TGA, single ventricle, and aorta is arising from outlet chamber. So this is a long list in which cases we get coarctation. Bicuspid aortic wall is again common association seen in 1 to 2%. Diagnosis of VS is challenging. Not all cases are diagnosed. Till recent series is only 18%. So only 20, 1 out of 5 cases of coarctation are diagnosed. So 4 out of 5 are missed. So we have to keep as a antenatal screener threshold low in a diagnosis of coarctation. Now just look at this image of aortic arch. This baby is around 24 weeks and the proximal aorta is around 2.5, mid segment is 3, and isthmus is around 1.3 millimeter. So 1.3 millimeter, that's Z score is comes less than 3.5. So this is the aortic arch. Let's appreciate a distal tapering of arch. We can appreciate a neck vessel coming from the aorta. So this is again aortic arch with color compare. Appreciate a distal tapering. Now look at the four chamber view. The LV is very small, RV is dominant, LV is apex forming. There are no warning signs like non-apex forming LV or endocardial fibroelastosis, okay, or LV dysfunction, because presence of any of these points toward diagnosis of hypoplastic left heart syndrome. This is dilated MPA arising from the RV and a small aorta arising from LV. This is a strip I have taken from left to right. I'm just giving you orientation that as against the caudal strip, I have taken a left to right strip from MPA, then aorta I have seen them sequentially. Finally, we can see the SVC also in this loop. Okay. So relative size of MPA and aorta is important. So this is size of MPA, the little bit of short axis view. Look at this is the aortic annulus and this is MPA. Another case, the LV was small, RV was dominant, so did aortic arch. So whether it is a physiological variation or not, but a dominant RV, we should always keep a suspicion in mind that aortic arch may be dominant. Another case, RV is dominant, LV is small, LV is up to apex. Now look at this aortic arch, which is significantly tapering and difficult to trace till the here to duct and aortic arch meet. And also note the relative size of arch as against main pulmonary artery. This is again a modified three vessel view. This is the MPA and this is aorta. This is aortic arch. Isthmus is just 1.26. This is a very a small aortic arch. Same patient we are talking about. Distally tapering. I'm just demonstrating a left SVC in this case because there is a theoretical possibility that left SVC leads to decreased flow of or decreased LA volume, decreased flow in LV, and possibly associated with increased chances of left-sided obstructive lesions. So this is the left SVC. This is the MPA arising from RV, and this is left SVC. This left SVC. Take a note of this strip. Okay, the aorta proximally, though LV is small, RV is dilated. The aorta distally suddenly tapers off of the first or second branch, where MPA remains big size. Okay, so note a distal tapering of aortic arch. Otherwise, there is no appreciable VSD in this case. And the left SVC can be seen transiently here in this part is the left SVC. Now we can do fetal echo even the term baby and demonstrate in the complex pathology. So this can help to deliver the baby in a good setup where it is possible to give immediate care. So in this baby, it was a coarctation that was suspected at the term. Baby was 29 weeks, delivered within a day or two. It can prevent a neonatal emergency. So this is the main pulmonary artery, and this is the aortic arch. Appreciate the distal tapering of the aortic arch, suddenly dilated distal descending thoracic aorta. Also appreciate the slow flow in distal arch, narrowing as against the turbulent flow in, and significant flow in main pulmonary artery duct. So this is the aortic arch, this is the ductal arch. Coming to the last topic of this presentation, VSD with coarctation of aorta. These two lesions are frequently found together, difficult to distinguish between coarctation and interruption because interruption is commonly seen with VSD, especially type B interruption that comes with discharge or the interruption after left carotid. That is a type B interruption. VSD can be any type. It can be perimembranous, midmuscular, outlet, anything. Posterior deviation of outlet septum is also frequently seen in VSD coarct or VSD interruption. Now this is a malaligned VSD. This is the VSD aorta overriding. This is the small aorta, small left ventricle, dilated RV. So this is how the image looks like. This is the VSD. Okay, it looks hyperechoic shadow of the interventricular septum. The same patient again appreciate the T sign VSD, that the perimembranous VSD has got posterior high muscular extension, small LV, dilated RV. Okay, otherwise contractility, everything is okay. There is no endocardial fibrinostosis or any sign suggestive of single ventricular hypoplastic left heart. Matter looks little small. Whether these subsets are associated with interval pathology, difficult to comment at early gestation. Now this is the MPI with ductal arch. Note the relative size of main pulmonary artery. And now see the very thin string-like aorta. Aorta is very small, just a couple of millimeters. So sometimes it is very difficult to demonstrate aorta. People tend to see this only as a MPA, not demonstrating aorta and labeling. It can be labeled anything from top pulmonary atresia or truncus. So if we see only one vessel, always try to demonstrate another vessel. A color flow imaging may be helpful. A very small vessel may not be seen, but color flow imaging can show you another vessel. So again, relative size of main pulmonary artery, aorta, and SVC. There is no flow reversal in the aorta that we have to note here. All are showing forward flow. Again, similar case of perimembranous VSD is seen here. This is the perimembranous VSD. Note the size of LV and RV. LV is small, RV is dominant. Color demonstration of VSD. The color flow going across the VSD. Now note the size of main pulmonary artery. MPA is big, arising from right ventricle. Main pulmonary artery is arising from right ventricle and it is big. And now this is a difficult image to see, but this is the proximal ascending aorta. It is difficult to trace, and this is a distal arch. And there is aberrant left subclavian origin. I will demonstrate this in next slides. So this is the aberrant origin of left subclavian, right subclavian, sorry. So this is dilated MPA. This is the aorta, and this is the SVC. So this is MPA. This is the aberrant origin of subclavian artery that goes here, and aorta is difficult to trace here, so that gives a possibility of interruption of aortic arch. I just drawn here. This is vertebra. This is MPA. This is aorta. This is SVC, and this is aberrant right subclavian. This is aberrant right subclavian. Just appreciate this image. It's a little difficult to appreciate, but that's how it looks. In cases of interruption with just we can appreciate the entire length of the aberrant right sub. Interruption in this case. Now this is multiple mid-muscular VSDs. Another case. This is a modified view, not very typical view. This is again mid-muscular VSD, aorta. These are the pulmonary veins draining into LA. You can appreciate the movement of aortic wall. Again, both the VSDs are seen, perimembranous and mid-muscular. Dominant right ventricle, small left ventricle, small perimembranous VSD. This is a posterior placed plane, so we cannot see all the VSDs there. You can just appreciate one VSD in this case. Okay, so these are we can appreciate the pulmonary venous drainage, small left ventricle up to apex, right ventricle. Okay. Pulmonary arch, ductal arch, aorta, and SVC. Note dilated main pulmonary artery. Note relative size of pulmonary artery as against aorta. Small is the SVC. So there is a big size discrepancy between these two. And in this case, we can just barely able to trace the aortic arch with the color flow. So this color flow, continuous flow that you see is the aortic arch flow. As against this, that is showing the MPA ductal flow. So this turbulence or slow continuous flow is aortic arch flow and ductal flow. Now this is important image. This is the pulmonary wall opening. You can appreciate tricuspid pulmonary wall with aortic wall that is eccentric opening little thick, suggestion of a bicuspid aortic wall. So note this short axis view showing bicuspid aortic wall. Difficult to see, but it's seen very well in this image. So after difficulty, I could trace the distal aortic arch that was 1.9. The Z score was less than 4 at 29 weeks. So this is the end of this first presentation. I hope you will like it. So every Wednesday at around 9 p.m. we will discuss 3 to 4 topics on fetal echo.